Hello, dear friends. Welcome to yet another session of this comprehensive clinical class. And today we have with us Mr. Vishal, who's a third-year MBBS student from MVJ Medical College and Research Hospital, presenting a case of trigeminal neuralgia. And we also have with us Professor R Chandra, ma'am, who will be moderating the session. Thank you both, Vishal and ma'am, for having agreed and being with us for this session, ma'am. Ma'am, with your permission, could we please start with the session?
Yes, ma'am. Start. Vishal.
Good evening. Good evening, ma'am. Good evening, sir. I'll start now. My name is Vishal from MVJ Medical College. I'm a third-year medical student. Today, I'm going to be presenting a case on the hidden connection, exploring neurovascular interplay in trigeminal neuralgia. Okay. My patient, Dr. XYZ, is a 48-year-old male doctor from Bangalore. He completed his post-graduation and he's of upper class in the socio-economic status. He was admitted in our OPD on the 24th of April 2022. He came with chief complaints of unilateral shooting pain on the left side of his face since 1 year. The pain was apparently normal. The patient was apparently normal 1 year ago when he complained of transient attacks of unilateral pain on the left side of his face. This pain was insidious in onset, gradually progressive, lasting for a few minutes, shooting in type for 1 year. However, the frequency and intensity increased over the last 2 months. There were no aggravating or relieving factors. Diurnal variation was seen in the morning, which woke him. Postural variation was not seen. No history of triggers, sensory loss, or weakness on the face, or head trauma. Past history. No similar complaints in the past. History of multiple root canal treatments. History of chickenpox in childhood, history of kidney stones, which was an incidental finding, and frequent urinary infections. History of hypertension since 5 years. No history of diabetes, tuberculosis, epilepsy, or asthma. Family history. No similar conditions seen in the family. Personal history. Diet vegetarian. He had a normal appetite. Bowel and bladder movements were normal. He had adequate sleep. No consumption of alcohol or tobacco. Drug history. Olmesartan was taken for hypertension and allopurinol for increased blood urea levels. General physical examination. The patient was well-built, conscious, cooperative, and well-oriented to time, place, and person. Pallor, icterus, cyanosis, clubbing, edema, and lymphadenopathy were absent. Vital signs. Blood pressure was 117 by 80 millimeters mercury. Heart rate was 110 beats per minute, regular in rate, rhythm, volume, and character. Respiratory rate was 14 cycles per minute. Temperature was 97.8 degrees Fahrenheit. Systemic examination. There were no abnormalities seen in the cardiovascular examination and respiratory examinations. And no abnormalities were seen also in the abdominal examination and in additional systemic examinations. However, only in the CVS examination an abnormality was observed. That is, during the cranial nerve examination, the function of all the cranial nerves are normal except the sensory component of the trigeminal nerve, which demonstrated with severe shooting type of pain on tapping center trigger points on the base of the nose, cheek, and over the maxilla on the left side. The remaining CS examinations were found to be normal. On radiological investigation, a coronal MIB image of 3D time of light non-contrast MRI angiogram of the brain showing circle of Willis and major arteries of the brain of the patient who experienced with clinical suspicion of trigeminal neuralgia. Here we can see that the right superior cerebral artery originated from the P1 segment of the posterior cerebral artery, whereas it usually originates from the basal artery itself. A similar trend was observed on the left side as well. And on non-contrast MRI of the angiogram of the brain, circle of Willis showed the major arteries of the brain. The red artery shows the basilar artery, and the blue artery shows the blue arrow shows the left superior cerebral artery from the P1 segment of the posterior cerebral artery, and the green arrow shows the origin of the right superior cerebral artery from the P1 segment of the right posterior cerebral artery. On high resolution CISS sequences in axial and coronary images, it was found that the root of the left trigeminal nerve was about 3.3 millimeters distal to the root entry zone and just proximal to the transition zone in the mid half of the cisterna segment of the nerve. We can also see the similar thing in these images. Differential diagnosis: trigeminal neuralgia, glossopharyngeal neuralgia, dental conditions, multiple sclerosis, reactivated herpes zoster infection. Provisional diagnosis: based on the radiological findings indicating neurovascular contact between the left superior cerebral artery and its branch with the left trigeminal nerve, a provisional diagnosis of neurovascular compression syndrome. This diagnosis is highly suggestive of trigeminal neuralgia, giving the patient presenting symptoms of unilateral shooting pain on left side of the face. Management: the patient was prescribed pregabalin to relieve the symptoms of pain associated with trigeminal neuralgia. Regular follow-up appointments were scheduled to monitor the patient's response to treatment, assess pain levels, and evaluate any potential side effects or adverse reaction to the medication. Significance of this case: this case is noteworthy due to the rare neurovascular interplay observed in trigeminal neuralgia. The patient's unilateral shooting pain exacerbated during sleep, along with unique radiological findings of neurovascular contact between the left superior cerebral artery and the trigeminal nerve, set this case apart. The diagnostic complexity and specialized management approach underscores its significance, shedding light to the intricacies of neurovascular related pain or shooting related pain conditions. I thank Vitamin for giving me this opportunity.
Okay, ma, nice. But you have gone through the theory revision. That's okay. But for students, it is important to know the anatomy, pathology, physiology. That's what important. Trigeminal neuralgia is not a rare disease because you are an undergraduate student. Maybe you are seeing the first case. It is a very common condition only. And neurovascular conflict syndromes are also not uncommon. It is very, very common. No, so that's okay. So in your presentation, you should learn to analyze the symptom. That is what is important. You said that allopurinol is given for urea. Allopurinol is not given for urea. It is given, maybe he has got a raised uric acid. Urea means kidney disease. Urea and creatinine will get elevated when there is a kidney failure. For that, allopurinol is not the treatment. You correct the hyperkalemia, acidosis, all those things will be pharmacologically treated. What is the cause for the kidney disease will be treated. And if the creatinine goes above 7, it is dialysis. And if it persists, it is transplant. Allopurinol is for uric acid. Okay.
Okay.
So that presents as joint pain. And you have told that this person had a shooting pain.
Yes, ma'am.
So here as an undergraduate, what you have to learn is what is the definition of pain and what does shooting pain indicate. You see, so what is the definition of pain? You are just fresh, no, from physiology.
Yes,
so how do you define pain? Pain is defined by whom? One is Sherrington. Okay. The electrophysiology, rotating drum and all is there. That person is Sherrington. So, and it is modified by the International Pain Society. So pain is that, those are the things you should learn from this case. So pain is defined as a psychic adjunct of an imperative protective reflex. So that is the definition of Sherrington, psychic adjunct of a protective reflex. So the organism senses a danger, so it produces a clinical psychological syndrome that results in pain. Why the psychology? Because you see, supposing you go for beauty treatment with all kinds of plucking of hair and peeling of skin, so many things people do know, yes. And they don't feel pain at all. Or these people like Michael Jackson or someone who just cut off his skin to become white, they never experience pain because they are wanting that. So they feel it is happiness. Whereas if you have tumor, cancer, something like that, even before the surgery starts, the pain starts.
Yes, ma'am.
So the psychological component is very relevant in the experiences of pain. So that is why it is defined like that. So International Pain Society has modified Sherrington's definition as psychic adjoint of an imperative protective reflex or anything that the person feels hurts. So pain can be purely psychological. Somebody will put a piercing hurt in your heart. I'm sure you will feel that pain so much. No?
Yes,
The
ma'am.
pain is psychology. Component of a protective reflex. That is the definition. So that you should know. Second, what you should know, what is the pain pathway and what are all the kinds of pain that you experience in the neurological words. Pain pathway is, what are the receptors? Pain receptors. You have got to see pain peculiarity of the pain receptor is what is the peculiarity of the pain receptor?
Ma'am,
Naked nerve endings, we call. No, you have got
Yes,
for touch, pressure, measles, corpuscle, pacemian, corpuscle, cross, and well, that's all for other sensation. For pain, it is said that the unmyelinated nerve fibers or the naked nerve fibers. What is the other name for the unmyelinated or poorly myelinated nerve fiber is C fiber and A delta fiber.
okay.
So they are called naked nerve endings because they don't have myelin. Or very less myelin, no receptor. Why there is no receptor? Because pain is protective.
Yes.
So any sensation beyond threshold will be appreciated as pain only. So unlike cold, there is a cold stimulus. Heat, there is a heat stimulus. Touch, there is a touch stimulus. But for pain, there is no specific stimulus. You keep on pressing your skin, finally it becomes pain. You keep on ice piece on your skin for quite some time, it is no more cold. It becomes pain. No? And you put your hand on the fire, what do you feel first? Pain or heat?
Pain, ma'am.
Good, very good. What is that phenomena called? Lewis double response.
Okay.
You are just from the physiology, no? So
Yes,
you
ma'am.
put your hand on the fire, you don't feel heat, you feel pain. So that you will remove your finger. And after you have taken out the finger, you get the second response, that is heat. So what caused you pain is heat. So pain has no specific stimulus. Any stimulus which reaches the injurious level of insult, that becomes converted into pain. So it can be deep touch, pressure touch, squeezing, pinching, keeping eyes over long time, heat, anything becomes painful when it is beyond threshold and it becomes potentially dangerous to the organism.
Yes, ma'am.
And that is what is demonstrated by the Lewis experiment, that is called Lewis double response. You put your hand into any injurious thing, let it be 0 point ice, then also you feel severe pain because the severe cold can produce frostbite, gangrene, and you lose your fingers. So you remove it. After that, you know it is a cold injury, thermal injury. So that is stimulus. So there is no specific stimulus for pain. Any sensation beyond threshold is appreciated as pain because it is a imperative protective reflex. Psychic adjoint of an imperative protective role. It has to protect the organs. So there is no specific stimuli. Any sensation beyond threshold is pain. So one unique feature is lack of specific stimuli. Any specific stimuli can produce pain. Second, most of the sensations adopt. You might see people who are living in the market where all decayed vegetables, everything will be around. They will be sitting very comfortably. But you go there and you feel you cannot stand there for a long time. Why? Because it is professionally their job. They sit there and their sensations adopt. So they no more suffer from the bad smell or noisy environment in the market. But you are a new person, so you are not able to tolerate. So all sensation or most sensations adopt, whereas pain does not adopt. The unique features of pain, there is no specific stimuli. It is only the naked nerve endings, which is constituted by C fiber and A delta fiber. Second, pain does not adopt. Because if it adopts, once you are burned and second time you burn, you adopt means you will damage your body part.
Yes, ma'am.
So pain does not adopt. Any number of times the insult is caused, every time the pain will be appreciated. Then these are the two unique features. Then pain is carried through the A delta and the C fiber, and it lies in the peripheral nerve. In the peripheral nerve, there is something called filtering of unwanted sensation. That is the large myelinated proprioceptive fibers inhibit the A delta and the C fiber to prevent the transmitting all unwanted impulses above. Then it goes to the dorsal root ganglia. In the dorsal root ganglion, again there is a second level of filtering, and then it enters into the dorsal horn of the spinal cord, where there is a area called substantia gelatinosa of Rolandi. In the substantia gelatinosa of Rolandi, again the unwanted sensations are filtered at the third level. Otherwise, there is so much environmental stimuli, we will be constantly disturbed. So that is the third level of filter. That the filtering in the substantia gelatinosa is called as what? You are first from physiology, you must have read Ganong, no?
Yes, ma'am.
Yes. What is the theory called? Gate control theory of Melsack and Wald. So it is said that there is a third gatekeeper for sensory transmission in the substantia gelatinosa of Rolandi, where the next level of filtering of sensation to only that is needed to be protective will be transmitted up. So then it is sent off. Then this goes into, pain goes into spinothalamic pathway, touch goes into posterior column and ventral spinothalamic pathway, goes up, it reaches the thalamo-mesencephalic junction. That is between the thalamus and the midbrain. What is special in that region? Lot of endorphins are there. Endorphins are endogenous morphioid compounds. So that will again suppress unwanted transmission from going up.
Yes.
So that is the fourth or fifth level of filtering. Then these pathways are organized into three groups. One is the thalamic group, second is the subthalamic group, third is the limbic group. Thalamic group will go into the thalamus, ventrolateral nucleus of the thalamus. And then it goes to the sensory cortex and the sensation will be appreciated. This is pain or touch or whatever it is. Then the subthalamic group goes to the motor cortex. And the limbic group goes into the frontal cortex. Why? You see, supposing what is the limbic cortex means? You might have all heard that famous quotation, "You too, Brutus," like, no? When the Julius Caesar was stabbed, when his trusted person is stabbing him, then he say, "You too, Brutus." That pain will be very severe. So that is the limbic component or the frontal component. Supposing your father says you are a bad boy, you will be very sad. Somebody on the road is saying you are not bothered because he doesn't know anything about you and he can have his own opinion. But your father knows everything about you, and if he says something, you will be very much upset. So that is the limbic component that alters the pain experience. Then you have got the subthalamic component, which goes to the motor cortex. Why? When you have a pain and which is likely to be injurious, you have to move away. That moving is an action. It is not sensation. So sensation has to be converted into an action. Then only you can protect the person. You see a thorn pricking your feet. You have to remove your leg from there. You cannot just keeping the thorn and saying, "I am feeling the pain. Unless you do the motor activity of moving your leg, what is the protection that you get from the pain? So sensation has to be converted into a motor component. Then only you protect the organism. For that, the subthalamic component is there. Subthalamic component goes to the subthalamic nucleus, then to the motor cortex. So the pain which is experienced is sent to the subthalamic component, then the motor cortex, so that the body part is moved away from the painful location. Is it clear?
Yes, ma'am.
Yes. So this is the pain pathway. So what you should know from this case, definition of pain, what is the pain transmitting mechanism, what are the unique features of pain, and how is pain carried. Right. That's. Then what are the kinds of pain you have? For the neurological point of view, you told there's a shooting pain.
Yes, ma'am.
You can have you can have a root pain, you can have a nerve pain, you can have a tract pain, and you can have plexus pain. So many pains are there. So each one has got one character. Roots for the peripheral nerves, root or the cranial nerves. Cranial nerves or the peripheral nerve, when it comes out from that area, at that narrow point, if it is irritated, it produces a shock-like pain. So shock-like pains are called root pains. It can be sensory roots of the cranial nerves or sensory roots of the peripheral nerves. So C5, L1, L5, lumbar roots, cervical roots, disc disease. In the intracranial compartment, it is some tumors or some irritative lesion, injury, things like that. So shock-like character is a typical feature of a root irritation. Why is that shock coming? That will decide which root is irritated. Okay. Whereas, and usually these root pains have precipitating factor and relieving factors. They are called the triggers. The precipitating and relieving factors can be proximal or distal. When they are proximal, like a disc disease, you move the neck, then the disc becomes little more dislodged, it will touch the root and produce pain. That is the disc disease, so movement. Whereas, if you strike peripheral area, that is producing the pain, that is called peripheral triggers or tinal sign, something like tinal sign you can call, no? So that depends on what is the disease that is happening. If it is a disc disease of the root, then neck movement of the spine will produce. And if it is some other condition, depending on the condition, the triggers will vary. Exposure to cold, speaking, swallowing, touching, all this will produce the trigger for trigeminal pain.
Yes, ma'am.
Cold wind, touching, several zones. So they will keep like this so that cold wind doesn't come and nothing happens. So usually they keep like this. Or sometimes during the pain, they keep on rubbing their face. So they get some scars there. So those are the triggers. So this person has a trigger, which you mentioned, but somewhere you said there is no trigger.
Only while touching the places on the particular face, he gets pain.
That triggers, no.
Yes,
ma'am. Patient has got trigger. The nature of the trigger is this. I know that you are a small boy, just beginning to do a presentation. That's why I'm discussing like this. Okay.
Yes, ma'am.
Some mismatches will happen. We have made thousands of mistakes, and then we got old, now retired after teaching for nearly 30 years. So that's a difference is there. That's okay, but I'm just telling you contradictory statements. No triggers, but you are only telling about triggers. Trigger is there, and this is my trigger. That is one. Whereas nerve pain is directly tap the nerve. Ulnar nerve. Suppose you have got ulnar nerve. We call it as a funny bone. So whenever this bone strikes somewhere, you will get pain. No?
Yes, ma'am.
That is called tinal sign. So directly tapping the nerve is a trigger, means that is called tinal sign. That happens in nerve pain. So spontaneous shooting or movement related shooting doesn't come. You directly touch the nerve, it will produce the pain. That is the tinal sign. Then you got plexus pain. So plexus pain for an undergraduate student will look like appendicitis, diverticulitis. Supposing patient has got an appendicitis, at that time that pain is coming. No appendicitis, you have pain in the iliac fossa, and you are thinking it is appendicitis. Urgently, surgeon takes him to the theater. He is operated and appendix is removed. And in the post-operative period, patient develops weakness of one leg. Somebody will sue the doctor and say that it is anesthesia or surgical mistake. Actually, patient might not have had appendicitis. Maybe the beginning of a pluxopathy. Pluxopathy can be due to viral infection, demyelination, diabetes, then hemophilia, whereas hemorrhage into the plexus, so many causes. So in the beginning of the pluxopathy, depending on the plexus that is involved, brachial plexus, it may look like a heart attack. People will say chest pain. So you think it's a heart disease. And after you do angiogram, patient comes with weakness. Then you try to correlate. You see, like that. So lumbar plexus pain will be in the location of the plexus. So whichever plexus is getting sick, it will be in the location of the plexus. It can be easily mistaken as something else. It will not generally have a precipitating factor or a relieving factor like movement or tapping. It's not there. Instead, the pain will radiate along the nerves that comes out from the plexus. Supposing it is lumbosacral plexus, patient will say, my pain is along the anterior thigh and the medial thigh. So anterior thigh is femoral nerve, medial thigh is obturator nerve. Or if it is sciatic nerve, so it is multiple nerves. So pain in the location of the plexus and coming along multiple nerves is a plexus pain. Then you have got tract pain. You have got spinothalamic tract and you have got posterior column. So spinothalamic tract mainly carry pain and temperature. So the spinothalamic tract pain will be an ill-defined, superficial feeling of burning or feeling of keeping ice, whereas there is no ice, there is no heat. So that is spinothalamic tract pain. Whereas posterior column tract pain is, you got Lermit's heart. It's too early for you to hear all those things, small boy only. So you call it a Lermit's sign. Suppose you flex your neck, patient feels a shock-like sensation spreading down the spine. That is a posterior column tract pain. It is called Lermit's sign. LHER-MITT. Have you heard?
No, ma'am.
You are just entering the clinicals, I understand. You see, that is posterior column tract pain. Second, posterior column tract pain can be lightning pains. So suddenly some lightning struck my chest, some lightning struck my abdomen. So somebody will think that an MI occurred or an aorta dissected or where there was a perforation in the stomach. Like that people will think. So that is called a lightning pain. Third kind of posterior column tract pain is girdle sensation. The patients tell some tight band is around my thoracolumbar region. That is the third kind of posterior column tract pain. Then we say posterior column tract pain can be deep boring paresthesia, as if the flesh is pulled out from the bones. Whereas spinothalamic tract is a superficial thing because it is pain and temperature. Whereas posterior column carries proprioception. Proprioception is carried by which structure? Muscle spindle.
Yes,
so
ma'am.
muscle spindle is in the muscle. So posterior column will produce a deep boring pain as if the flesh is pulled out from the bones. That is a posterior column tract pain. So these are the, then you have got to go up. When you go up, you have got the thalamic pain. This organized the thalamic component I told. From the thalamic component, they go to sensory cortex. So in the thalamus, you can have a thalamic pain. Thalamic strokes. These people get a long period of severe disabling pain on one half of the body opposite to the side of the thalamic stroke. So it's called thalamic syndrome of Digerin. So they will have constant pain which will interfere with their sleep. So it's the thalamic pain. Then is the cortical pain. Cortical pain is purely psychological pain. You see, people will always tell you lose your loved one or you lose the gift received from a person who carries you very dearly. Then you feel that pain. We don't tell, I am sad. We feel pain. You feel the pain, no? Experience pain. This is a purely psychological pain. That is in the cortex, limbic cortex. So there's a various kinds of pains. So this is the third thing you learn from this case. What is the definition of pain? What are the pain transmitting pathways? What are the types of pain? So this you will revise today. Okay.
Yes, ma'am.
That's all. So now, where is your patient? So your patient's pain looks like a root irritation pain.
Yes, ma'am.
Shooting pain. So I said it is a root pain. So which root is irritated? That depends on the location where it is experienced. Supposing you experience in the hand, it is a cervical root. He experienced in the face. So face sensory supplies by the trigeminal nerve. We know that. So trigeminal nerve root is irritated. So it's the first thing you will tell about neural in this case is, madam, my patient had a root kind of pain.
Okay.
And this root kind of pain is in the distribution of the trigeminal nerve root. No? Something is irritated in the sensory root of the trigeminal nerve. Next, you will ask which division. How many divisions the trigeminal nerve has got?
3, ma'am.
Yes. Ophthalmic, maxillary, mandibular. So
Yes.
which division was affected in your patient?
Ma'am, all 3 were affected.
All 3. So I can say my patient's pain was in all 3 divisions. So your history diagnosis will be your root pain coming from the sensory divisions of the ophthalmic, maxillary, and mandibular components of the trigeminal nerve is happening in my patient. So all the nerve roots are together at what place?
Ma'am, the trigeminal ganglia.
So it can be in the trigeminal ganglia. Second, in the root exit zone.
Yes, ma'am.
The cysternal space when it is just emerging. After that, it divides. So would you like to trace the trigeminal nerve now? That is the third thing you should learn from this case. So you say that it has got a motor nucleus and it has got a large sensory nucleus. Motor nucleus is in the pons. And the sensory nucleus has got 3 components. Mesencephalic component, chief sensory nucleus, and the spinal tract of trigeminal. The spinal tract of trigeminal comes up to the C4. Chief sensory nucleus, and it carries pain and temperature. Chief sensory nucleus is in the pons. The mesencephalic nucleus is proprioceptive. So this is spread very big. Sensory nucleus is from the midbrain to the cervical cord, whereas the motor nucleus is in the pons. So they are, so that's a nucleus. Above the nucleus, so I always tell that as an undergraduate boy, when you learn any cranial nerve, try to learn it under certain headings. So to diagnose trigeminal neuralgia, when you graduate, it is not at all difficult. It is a very common condition and it is a smarter diagnosis. You listen to the story, you diagnose. But you are small boy, so you think it's a very rare disease. It is not, no? So, but what you should learn is the anatomy of the trigeminal nerve. I always tell any cranial nerve, learn in this order, then by the end of your MBBS, you will want to become a neurologist. No? So, because neurology is the only subject which is mathematics. Anatomy, physiology, common sense, commitment, and the mathematics of it. So mostly you will sit on the diagnosis. So supranuclear, nuclear, intraaxial fascicular, cysternal, skull base, foraminal. Any cranial nerve, you have to study like that. Supranuclear. I just told about the nucleus. So above the nucleus is supranuclear. So what is the supranuclear part of sensory nerve? It goes to the thalamus, thalamocortical projection to the sensory cortex. So that is the opposite cortex. So supranuclear part of the trigeminal is in the thalamocortical projection on the opposite side, opposite sensory cortex. And second, what is the supranuclear motor? It is in the precentral cortex, in the motor cortex. And so what, is there any unique feature for this in the supranuclear? That is the second. So supranuclear part of the fifth nerve is in the motor component is in the motor cortex, the superior lateral surface where face is represented. And the sensory cortex is on the superior lateral surface in the postcentral gyrus where the face is represented. What is the unique in the motor component? What is the unique in the sensory component? Like that, you have to make a template and fix it in your brain. So motor component, you know, the trigeminal nerve supplies muscles of mastication.
Yes,
Supplies masseter, temporalis, medial pterygoid, lateral pterygoid, tensor tympani, tensor valli palatini, anterior belly of the digastric, and mylohyoid. So these are the muscles supplied by the motor part of the trigeminal nerve. All these are supplied bilaterally. So right motor cortex and the left motor cortex will supply both the muscles, both muscles, except masseter. So in the supranuclear component, the unique feature is masseter, supranuclear fibers, the masseter is contralateral, whereas all other is bilateral. So that is the unique. So just fix it like that. You have to learn it. You never think neurology is complex. Neurology is beauty. The nervous system is the greatest system in the human body. Without the brain, what you are? You see, I always think that the best way of dying is to get a heart attack. So simply do angioplasty, bypass, and convert the human beings into vegetables, and then all their relatives will start hating. You become demanded multiple infarcts due to the multiple procedures, and you cannot die. So that is not the best way of dying. Best way of dying is an acute myocardial infarction. That's the best way of dying. Whereas it's never get a brain disease. You cease to be yourself. Then there is no point in surviving. So that is the important. So supranuclear component, motor component, masseter alone is contralateral. All other muscles are bilateral. Supranuclear component. Second, sensory. Is there anything unique in the sensory? The supranuclear component. We know that in the trigeminal nerve, angle of the mandible is supplied by the ansa cervicalis.
Yes, sir.
The face. So it is not supplied by the trigeminal nerve. Whereas the supranuclear part, there is nothing like ansa cervicalis and trigeminal nerve. The whole of the opposite face is supplied by the sensory part. So these are the two unique features. Motor, masseter is contralateral, all others are bilateral. Sensory, including the angle of the mandible. So it closely resembles a psychogenic facial sensory loss that you differentiate by looking at the angle of the mandible. Angle of the mandible is also supplied by supranuclear component. That is a unique feature of the supranuclear. Then come to the nucleus. The nucleus, we saw the long sensory nucleus and the small motor nucleus. They are kept in two different sheaths. So generally, the whole thing does not get affected unless there is a huge lesion in the brainstem. So in the nuclear component, each one gets separately affected. Motor nucleus can get affected without involvement of sensory. That is the motor neuron disease. So wasting of the facial muscles you will see. Sensory can be separately affected. Supposing you have got a high cervical cord disease, you will only have the spinal tract of trigeminal involved. So you look at the face, it will be pain and temperature alone. Touch and proprioception will not be affected. And the pain and temperature, there is a unique pattern. The forehead is below, maxillary part is second, and mandibular part is top. So the lowest lesion will involve the forehead sensory loss. Little more higher, it will be maxillary. Little more higher, it will be mandibular division. And it will be pain and temperature. So the spinal tract of trigeminal, commonly syringobulbia, syringomelia, craniovertebral junction anomalies, high cervical cord compression, those conditions. Supposing it is a chief sensory nucleus, it will only affect touch. So facial touch will be lost, pain and temperature will be not affected. So if it is the mesencephalic or proprioceptive, it is the muscles position. So when they are chewing, patient, if you have mesencephalic, like syringobulbia involved in the midbrain, or a demyelinating lesion in the midbrain, or a glioma in the midbrain, patient will tell, when I am chewing, I bite my cheek. So they do not have the muscle sense. It is proprioception. So when they chew, the muscle doesn't stay out. It will come in between the teeth. So I don't know, madam, why it is happening. I am biting my teeth very often. Either you have to find out an aberrant teeth. If that is not there, it is a mesencephalic component of the fifth nerve that produces proprioceptive dysfunction of the muscles of mastication, resulting in biting of the cheek. So that is sensory, this is motor. And sensory and motor, unless there is a huge brainstem disease, in the nuclear level, they are not together involved. They involve separately because sensory is so large, motor is so small. To knock out both the sensory and motor, you should have huge lesion. By the time patient will be dead. This is suppose you have got an infarction from the midbrain to the medulla, patient will stop breathing. Respiratory centers and all is there. So they don't come to you alive. So if there is a large lesion, it is unlikely to be nuclear. In the nuclear level, it is either motor or sensory. And depending on which part, the sensation may be pain and temperature or touch or proprioception. And motor is usually muscle wasted. That is a nuclear part. So supranuclear part, nuclear part. I am trying to make it as simple as possible. I hope you understand.
Yes, ma'am.
Next, you got the infranuclear. So what is the intraaxial fascicular? What is intraaxial? Before it leaves the pons and comes to the cysternal space, for a short period, it is in the substance of the pons. That is called intraaxial fascicular. The nucleus has given rise to these fibers. They are joined together. It is in the substance of the pons. That is called intraaxial fascicular. There you identified by the company it keeps. Pons has got other cranial nerves. You know that pons has got the 8th cranial nerve. It has got the 6th cranial nerve. It has got the gaze center, and it has got corticospinal tracts. So involvement of the 5th nerve along with other structures in the pons, that points to intraaxial fascicular 5th nerve involvement. So supranuclear, I told what are the unique features. Nuclear, I told you what are the unique features. Intraaxial fascicular. So you know where exactly my nerve is involved. Then you have the diagnosis, you see. And then it comes out. And as you said, it lies in the petrous apex. Before the petrous apex, it has got a cysternal part. So it has left the pons and it is coming out as a sensory motor complex and bathes in the CSF, in the peripondine cistern. So that is called the cysternal phase. This is the only place where complete motor sensory trigeminal nerve knockout can happen, because here it is all together. In the cortex, precentral or postcentral, in the brainstem, it is long sensory and small motor. And in the intraaxial fascicular, of course, the brainstem company is there. But in the cysternal space, there is no brainstem, but sensory and motor are tightly packed. So supposing you have got a person who is having motor paralysis and sensory paralysis of the trigeminal nerve complete with no other accompaniment, it is in the cysternal phase. There is no extraaxial. So the key point is combined sensory motor trigeminal nerve paralysis is extraaxial. It is not supranuclear, it is not nuclear, it is not intraaxial fascicular, it is in the extraaxial place. Then only everything is compressed into one bundle.
Yes.
Understood? So that is the cysternal space. Then skull base. So supranuclear, nuclear, intraaxial fascicular, cysternal, skull base. In the skull base, it comes and lies in the petrous apex. In the petrous apex, you have got the sensory and the motor component in the cavum trigeminal. It is situated in the cavum trigeminal. On that, you have got venous sinuses, superior petrosal sinus, inferior petrosal sinus. That's all there. So supposing you have got a ear infection, chronic otitis media, and that produces septic venous thrombosis of the venous sinuses, petrosal sinuses. That will spread like that and reach the petrous apex and produces a petrous apex inflammation. That is called Grady-Negro syndrome. Because it is an inflammation, septic thrombophlebitis, and next to the trigeminal is the 6th nerve. So it will be combined involvement of the 6th and the 5th nerve together. That is called Grady-Negro syndrome. So that is skull base. So in the skull base, it is in the petrous apex. It is usually close to the 6th nerve. So generally it produces 6th and 5th. And that is called Grady-Negro syndrome. Then immediately look at the eye, ear, it may be chronic otitis media. that has produced this, and it may be septic thrombophlebitis. Clear, no? So
Yes, ma'am.
it is distinct, nuclear it is distinct, intraaxial vesicular it is distinct, cysternal distinct without any accompaniment, combined sensory motor fifth is cysternal. Then skull base is petrous apex. Then you come to the divisions. It lies in the lateral wall of the cavernous sinus. Then the foraminal part comes. Ophthalmic division goes into the superior
The
orbital
orbital fissure, and the maxillary goes into the
foramen.
foramen ovale, and the mandibular goes into foramen magnum.
So mandibular goes to the foramen rotundum. Sorry, foramen ovale. Maxillary goes into the foramen rotundum. So ophthalmic goes into the superior orbital fissure. Mandibular goes to the foramen rotundum, sorry, foramen ovale, and maxillary goes to the foramen rotundum.
Okay. Yes.
So it goes to the ophthalmic superior orbital fissure, maxillary foramen rotundum, mandibular foramen ovale. So when it comes to the skull base, it is no more combined sensory motor fissure. Ophthalmic division goes to the superior orbital fissure and keeps company of the oculomotor nerves.
Yes, ma'am.
3, 4, 6. That we call it as the superior orbital fissure syndrome. So once it has come out of the cysternal space, again it is not at all together. That is why I told if it is combined together, it is cysternal space or in the cavum trigeminal. Beyond that and before that, it is all separate. In the ophthalmic division, it enters into the superior orbital fissure, keeps company of 3, 4, 6, and along with that fifth together, you call it a superior orbital fissure syndrome. Then the maxillary division reaches the infratemporal fossa, supplies the middle of the face sensation, and it usually is alone. Then the mandibular division is lower part of the face with the motor component. So motor component and inferior it is the foramen ovale. So if it is involved in the foramen ovale, it is only the lower face plus all the muscles of mastication that get involved. Of course, you have got this infratemporal fossa. All this in the infratemporal fossa is here. It is nasopharynx. So nasopharyngeal tumors, like what I told, petrous apex, CSOM, superior orbital fissure, inflammation, Tolles-Hunt syndrome or superior orbital fissure syndromes. Whereas maxillary division and other divisions, they get involved in nasopharyngeal tumors. So nasopharyngeal tumors infiltrate into the trigeminal nerve and produce varying combinations. We call it as Trotter's triad, Jacobson's triad, depending on whichever company it is keeping. And then it supplies the muscles of mastication. So this is tracing the fifth nerve from the supranuclear, nuclear, intraaxial fascicular, cysternal, scalpic foramen. So in your case, it is a root irritation. It is purely sensory without any root signs. So you have almost completed your presentation. You did not have any sensory loss.
No, ma'am.
So it is no root signs are not there. Only root pains are there.
Yes, ma'am.
So that is a unique feature. So you say my patient has got a root pain. Probably it arises from the sensory roots of the trigeminal nerve, but my patient does not have any root signs. So it is a irritative lesion of the sensory division of the trigeminal nerve. It is not a destructive disease, like a trigeminal schwannoma, nasopharyngeal carcinoma. No?
Yes, ma'am.
They are all destructive diseases. They will produce pain and sensory loss. So when there is pain and no sensory loss, it is a purely irritative disease. It is not a destructive disease. So that much information you can get. So without MRI, MRI is only an adjuvant. MRI rarely gives the diagnosis. MRI without the patient is zero. No? So
Yes.
with the history, you can tell my patient has got an irritative disease of the sensory roots of the trigeminal nerve. There is no sensory loss Therefore, it is not a tumor. It is not a cholesteatoma. It is not nasopharyngeal tumor. It is not trigeminal schwannoma. It is some kind of irritation. So what are all the irritations that can produce this? That is the question. There are many things. Once you told that this patient had multiple root canal treatments.
Yes, ma'am.
That is the inferior alveolar division is supplying the mandible.
Yes, ma'am.
And when you do multiple root canal treatment, you have to find out whether the patient has got a metal cap or a marble cap. Metal caps are all a little cheaper. Marble caps are little costlier. Metals are good conductors. Marbles are bad conductors. You see, when you put a good conductor there, this conducting thing gets established electrically with the nerve terminals. And it produces something called haptic conduction.
Okay.
Chronic dental caries and multiple root canal treatment with metal implants is one cause for trigeminal neuralgia.
Okay.
You mentioned that specifically.
Yes, ma'am.
Even though radiologically you find something, necessarily you should tell in this patient, if you remove the neurovascular conflict, I am not sure he will be relieved because he's already having multiple root canal. That may be causing. We don't know. You see, caries itself can lead to haptic conduction, chronic inflammation. Second, metal filling can lead to irritation and haptic electrical transmission resulting in circuits that become spontaneously firing and produce trigeminal neuralgia. That is one. Second, you might have had, you said you had chicken pox. Whether you had herpetic lesion there, that can produce that pain. Then you have got a idiopathic trigeminal neuralgia without anything. You see? Then neurovascular conflict syndromes. These are because you have got the dorsal aorta and the ventral aorta, and so many connecting arteries are there. Glossopharyngeal neuralgia, glossopharyngeal artery, aortic artery, facial artery, trigeminal artery. These are arteries which close at the time of birth. They are not functional. Soon after birth, they close. Sometimes they remain patent. And as you grow older, like all other vessels become atherosclerotic, these vessels also become atherosclerotic, become less flexible. They compress on the nerves nearby, resulting in irritation of these nerves. So you have demonstrated a neurovascular conflict, but many other factors also could be causal in this patient. Root canal treatment you told. So we don't know. So you have to give a guarded prognosis. If you are a neurologist or a neurosurgeon who is planning to operate this patient, you have to tell, sir, you have got other causes also. I don't know which is the culprit, whether this is just a shadow and the culprit is in the metal filling. So better remove the metal filling also and put some marble filling there.
Okay, ma'am.
So that is how. So you are going to diagnose. So your diagnosis at the end of your history will be a irritative lesion of the sensory division of the trigeminal nerve. Probably the irritation is in the cysternal place because all three divisions are involved.
Okay, ma'am.
It is distal to that, only one branch will be involved, mandibular, alar, maxillary, or ophthalmic. But all three divisions are involved. The irritation is happening in the cysternal plane. And you have demonstrated a neurovascular conflict at that level. Usually it is the anterior inferior cerebellar artery. In your case, you have demonstrated superior cerebellar artery. You can, pregabalin is usually not that useful. Useful is carbamazepine because it is like an epileptic discharge. That is more useful. And if these drugs are not useful, you can suggest the surgery. And surgery is invasive, removing the conflict. So you have got gamma knife. It is there in NIMHANS. You can send the patient to NIMHANS if it is not responding to treatment, medical treatment. They can go gamma radiation and ablation of the conflict areas. That can be done. Or they can also do ablation of the sensory root of the trigeminal so that it doesn't feel the pain. They can either burn the conflicting artery or they can burn the sensory division of the fifth. Burning the sensory division of the fifth is more safe than the artery. because you may develop a superior cerebral artery infarct. So it is better to lyse the sensory division of the trigeminal nerve with a gamma radiation. That is non-invasive. So sometimes you inject Botox injection into the trigeminal division for temporary relief or something. So, so this case is, you presented very well. You have revised so many things for your third year level. It is wonderful.
Thank you, ma'am.
Learning point is not to make a diagnosis. At this point, you should learn anatomy, physiology, little more concisely, and learn to correlate with the common sense and your clinical features, and then come to your diagnosis. Even if you know, I know trigeminal, why I will read? No. You know trigeminal, true. Use it as an opportunity to go through the supranuclear, nuclear, interaxial, fascicular, cysternal, skull base, foraminal, plane of the trigeminal nerve. Revise it 4-5 times.
Yes, ma'am, I'll do that.
And it becomes fixed in your brain forever.
Yes.
And teach your younger colleagues. Then it becomes more solid.
Yes, ma'am.
So good, ma'am. Nice.
Thank you, ma'am.
Any question?
No, ma'am, nothing else. Thank you.
Thank you.
Ma'am, thank you very much for your time, ma'am.
My time is for this only. What else I will do? I have grandchildren. That is the thing I have to do. That is my another responsibility and duty. Otherwise, this is my duty. Thank you very much. Thank you. Thank you.
Vishal?
Yes, sir.
Ma'am got disconnected. Vishal?
Yes, sir.
Ma'am got disconnected.
Okay, sir.
What happened?
So, ma'am, like we finished the presentation, sir.
Okay, ma'am left. Okay. Anyways, Vishal, thank you for the presentation. And thank you, Chandra ma'am, for this session, and thank you students as well for being a part of this session.
So thank you, sir, for giving me this opportunity to present my case.
Yeah, welcome.